Hello and welcome, everyone. I am Autumn Lintz, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A program. We are very excited to have you here today, and we are ready to get started. Before I introduce our wonderful panelists, I'd like to go over some housekeeping. Today, participating from the Foundation is myself. We are doing Q&A. That's what we're here for. Please add your questions to the Q&A tool or the chat tool on Zoom. We have had an unbelievable response with people sending in their questions ahead of time. We will do our best to be able to answer all of your questions. After a brief introduction, we'll get started with answering the questions. We will be recording this webinar and the video will be available on the Foundation's YouTube channel in a few days. We'll also send a link via email to all who registered as part of the follow-up email. We would like to thank our individual donors and our funding partners for making programs like this possible. We cannot do it without your donations and without our funders. This is how we exist, and this is how we are able to produce patient education forums, webinars, publications, and other education materials, so thank you for your donations. Upon conclusion, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. We do use the feedback to guide future programs and to ensure we are meeting the needs of the community. So please take the time to complete the survey. It should only take a few minutes. If you are not already on our mailing list, please join it. Visit our website for any educational information, join our community connections for peer-to-peer opportunity, and as always, follow us on social media to stay updated. Now, I would like to introduce you to our speakers we have with us today. First, I would like to introduce Dr. Mary Jo Lechowicz. She is Professor and Vice Chair for Education, Department of Hematology and Medical Oncology, Emory University School of Medicine. She is also a Margaret H. Rollins Chair in Cancer. She's a primary investigator for a number of trials at Emory with regard to improvement of care in lymphoma, particularly related to transplantation in patients with cutaneous T-cell lymphoma. She is currently active in the American Society of Clinical Oncology, the Discovery and Development Therapeutics Research Program, and the American Society of Hematology, American Association of Research. She is a member of the Discovery and Developmental Therapeutics Research Program at Winship. Next, I would like to introduce Dr. Keri Chaney. She is Assistant Professor of Dermatology at Froedtert and the Medical College of Wisconsin. Previously, she had been the Director of Contact Dermatitis Clinic at Brigham and Women's Hospital in Boston and a physician on the Cutaneous Lymphoma Service at the Dana-Farber Cancer Institute in Boston, Massachusetts. She has over 19 years of experience in the medical field. She graduated from Washington University St. Louis Medical School. She is board certified in dermatology with specialties in general dermatology, cutaneous lymphomas, allergic contact dermatitis, laser, and skin surgery. She has numerous peer-reviewed publications. She's also a valuable member of the Foundation, providing her expertise across many of our programs. Now we can meet them in person. So we want to go ahead and get started and welcome Drs. Chaney and Lechowicz. Dr. Chaney?
Hi, thanks so much, Autumn. I'm really happy to be here today.
Dr. Lechowicz?
Hi, welcome everybody. Thank you to the organizers for the Cutaneous Lymphoma Foundation for inviting me. I'm honored to be able to work alongside the two of you and to answer some questions today.
Great, let's get started with our questions. I've been recently diagnosed with stage 1A mycosis fungoides, and I'm wondering how common it is to have patches appear or get markedly larger seemingly overnight. I'm treating with cortisone creams currently, and it seems to help, but one patch clears and another takes its place within a matter of days. Is this normal?
I guess I can start out with this one. I think one of the hard things is everyone seems to follow their own path in cutaneous lymphoma, and there's not one course of disease that's common to everyone. So people with stage 1A disease tend to have a limited number of skin lesions. And people can develop new lesions at any time throughout the course of this disease. That's one of the hardest things, that, it's a chronic condition that we're constantly managing, not something that we can cure. And so it is common to get new lesions. Sometimes if people are doing ultraviolet light phototherapy, all of a sudden they'll see new lesions pop up, especially at the beginning, that they hadn't seen before they go away with the treatment. I would say getting new lesions in a matter of days is a bit unusual. And if you notice that you're getting many more lesions and they're becoming much more extensive on your body, then it's a good time to follow up with your dermatologist.
Thank you so much, Dr. Chaney. Have you treated interstitial mycosis fungoides? Is the prognosis the same as regular mycosis fungoides?
So interstitial mycosis fungoides, that would be a subtype of mycosis fungoides. It's not a common subtype. I have seen it in the past. The prognosis should be very similar to other subtypes. So depending on how extensive your lesions are and sort of how thick they are. If you have just patches and plaques, the thin lesions, or if you're developing tumors. So that will be sort of the biggest prognostic factor.
And Dr. Lechowicz, I know the first few questions really seem to be driven towards dermatology questions, but we do have some in here for you. Any information on how long patients are sustaining remission using mogamulizumab?
Maybe I'll take this one. I think part of it just for everybody to be aware in terms of the mogamulizumab being a systemic treatment that's often used with particularly with those that have Sézary syndrome, and it being a CCR4 inhibitor. The question, I think, brings up a lot of different things about the disease state itself, in terms of stage, in terms of presentation, in terms of tumors versus circulating cells and the like. And then it also has to do with the length of time of people using the mogamulizumab with regard to their treatment. I think what people are looking for possibly in the question is about length of time with the treatment itself in terms of staying in remission. And I think depending again on the stage, there's a number of different thoughts on that matter. I don't know if Dr. Chaney has thoughts as well. What we do know, because I always tend to think of things as 0.01% as 100% of somebody's experience, and so thinking about things like how the drug works itself in terms of if you've got circulating cells, we know that it works there the quickest, then followed by the rashes or cutaneous manifestations, and then possibly onto your lymph node manifestations. There's also some more recent data suggesting that, and maybe Dr. Chaney can comment on this as well, but as many people know that have, and I apologize, of course, this is remote, always fun when we do them in person, obviously not available at this time, but in terms of those people that have had mogamulizumab, also understand that many will have a rash from the drug itself, and it can be sometimes hard to tell the difference between the manifestation of the drug and the disease itself. And then we have some early data looking at the fact of whether that rash actually may indicate a better chance of improvement with the drug. I don't know if Dr. Chaney wants to comment on that.
Sure, I'm happy to say a few words. At my center, and I work with a medical oncologist, so I'm not the primary person prescribing the infusional medicines like this, but I follow quite a number of patients. I'd say we have at least 10 who are on mogamulizumab. And it's a drug that we haven't had in our armamentarium for very long. I believe it's only over about the last 3 years that it's been available here in the United States. And we have seen really remarkable improvement in our patients with Sézary syndrome. I've been not as impressed on how it what it does for mycosis fungoides. And we have some patients who have been on it for 3 years and have had a remission for that entire period of time. We've had some people who have not. And we've seen virtually everyone develop a rash at some point with it. And as Dr. Lechowicz said, it's very difficult to tell the difference between returning cutaneous lymphoma and a drug rash related to the mogamulizumab. And we're getting better at figuring that out, but it's still something we struggle with. And then once people are getting the rash, because it can be fairly bothersome, it's trying to determine how can we safely keep you on this medication, or do we need to stop and move to something different? So that's one of the things we struggle with. But I think there are people, in my experience, who have had a remission for 3 years, but that's not everyone.
Okay, thank you so much for both of those. Can UVB light treatment cause skin cancer? How is it determined? What is a safe level and duration of treatment to treat CTCL? And before you answer, there was a couple of questions along this line that I've combined into this one.
All right. I guess I'll start with that. But Dr. Lechowicz, if you have any question or any thoughts, please pipe in. We use different types of ultraviolet light to treat cutaneous T-cell lymphoma. Probably what's used the most is something called narrowband UVB. This is a very specific wavelength, 311 nanometers of ultraviolet B radiation, and it's very precise in its ability to both kill off cutaneous lymphoma cells in the skin and reduce the symptoms and signs that we see. It gets rid of itch, it gets rid of redness, and it does that by reducing inflammation in the skin. No treatment is without inherent risks. For the most part, narrowband UVB is not a potent causer of skin cancer. However, with hundreds of treatments, it may increase your risk of skin cancer, especially if you're someone who is at risk for developing skin cancers to begin with. So the other types of skin cancers we're talking about that can happen with ultraviolet light are things like basal cell skin cancer, squamous cell skin cancer, and melanoma. There's others too, but those are far and away the most common. For the most part, basal cell and squamous cell skin cancers are very treatable, particularly if they're caught early. Melanoma, we definitely like to catch early because it can be a much more serious cancer. Usually it takes hundreds of treatments, well above 300 or more, to see an increased risk of skin cancer. Now, if you happen to be someone who has a higher risk for skin cancer inherently, some of the things that we see for that are people who have had a lot of radiation, or people who have underlying other immune problems, things like CLL or organ transplants or other medical conditions that make you take a medication that suppresses your immune system. Those can increase your risk for skin cancer. And so then that's an additive risk. So usually most people doing phototherapy are doing it under the direction of a dermatologist who can screen them for skin cancer. And if you are doing ultraviolet light and you see changes in your skin, so lesions that bleed very easily, lesions that are painful or grow quickly, those are a good reason to check in with your dermatologist. But by far and away, it's a very effective treatment for cutaneous lymphoma. And in most cases, the risks are the benefits are much better than the risks are for most people.
All right, that's great to hear. Dr. Lechowicz, do you have anything to add on that one?
I don't know about to add, but I wonder if I could ask a clarifying question, possibly. Just in the last, obviously for the last 2, now starting on 3 years with COVID, we've seen kind of a movement from the dermatologist's offices, at least here, towards home units. And I wondered if you wanted to comment on that, or have any, because a lot of the patients will ask about, I think similarly to this question, or maybe some coming up, about sort of risks or what else they can look for. Is there anything kind of any different, or if you don't mind any kind of other suggestions you have?
No, that's great. And I think there were some questions about the cost of home units too, and I'll see if I can touch on that really briefly. So home phototherapy can be really useful, especially when we're trying to avoid going into medical offices and things like that, and just the convenience, because phototherapy is a big time commitment for patients. So especially if you're driving far away to someone's office and you're doing this multiple times a week. So, and there are studies in other diseases showing that home phototherapy can be just as effective as phototherapy in a dermatology office. It is harder because you aren't seeing a medical provider, even if it's just the technician that's running the phototherapy booth as often. But I think it still can be done safely, but it's still going to be very important to check in, probably depending on your history, at least several times a year, to make sure that you're having good maintenance of your disease, to get a complete skin check to look for anything that's changing on your skin. Once you get a booth, it's not a free pass where you can just follow up, in a year or two. I think it's really important to stay connected. Regarding the cost of booths, it's been very difficult. Medicare has not been very kind, at least where I live, in covering these for patients. And I think that's a really great disservice. And because Medicare has been hesitant to cover them for patients with cutaneous lymphomas, other insurers have not been covering them either. And I've been fighting for a lot of patients. It's fairly infrequently that we will get the whole body units covered. And the whole body units that we typically use to treat sort of people's entire bodies will cost many thousands of dollars if your insurance doesn't pick up the cost. So I'm working on trying to figure out what to do about this. But I would actually, if this has been one of your problems, go and write your local representatives in Congress, your senators, because this is a Medicare problem that we need to fix on a national level.
Thank you so much. So part of that question that they also had was about where to get it. Would it be best for them to work through their dermatologist for that?
So most of these units, you need a prescription from a physician to be able to purchase. There are occasionally you can get units from other patients who no longer need them. I would be very careful about purchasing something on eBay or Amazon or things like that, because you want to make sure that it's the right type of light, that it's safe, that it's calibrated, and that it will be an effective unit for yourself.
Okay, thank you so much.
So the two companies that I tend to use, are Davlin and National Biological Corporation. So those are two of the big suppliers here in the United States.
Perfect. Thank you. How do you know if mycosis fungoides will be aggressive or not? What signs do you look for? Having LCT, is it always a bad outcome? That's a tough one.
Dr. Lechowicz, do you want to start, or I can?
So yeah, I guess I'll start. So some of the so we do have, as everyone know, in terms of the cutaneous T-cell lymphoma being a part of the non-Hodgkin's lymphoma family. I think when people at least come to see me for an opinion, that's one of the concerns, is that they're often told that they've got lymphoma, and that they're left to sort of think about all the different types of non-Hodgkin's lymphoma there is. In terms of, I think there's a lot of questions within those three questions, so I'm going to try to attempt at a couple of them. I think one of the questions is how do you know, or how can we tell whose disease may or may not get better, or what are some concerns? I think, we know that there's the more extensive disease, so stage 2B and past, but I think the other things, at least that we often look for, are related to, and I'd be interested in Dr. Chaney's experience as well, is that the difference between kind of patches or plaques, do they start to look more nodular? There are things under the microscope, as we know, that give us a sense, are there larger cells? Are there some cells with different characteristics to them that make us concerned that they could be multiplying faster? And Dr. Chaney brought up a little bit earlier, when we were talking about early stage or stage 1A disease being less than 10% of your skin, if you start to see There are some people that will come into my office, and I'm sure many other people's offices, and it's almost as if a switch has been hit, and then they'll have a number of lesions kind of coming up at the same time throughout their body. That, or any kind of change in staging or change in approach to something you're used to, I think is something you need to talk to your dermatologist or your physician about. Other times we see things like, and at least what I talk to everybody about is, and I see people that have more systemic lymphoma, so unintended weight loss, night sweats, something that, glands that seem to be not go away, and or again anything that starts to look raised or more nodular or more like a tumor or even more like an ulcer, or something that frankly doesn't seem the same as it was before. Those are the places those are the types of changes that I get concerned about. We're still, with that in mind, there's many different things that we're looking at across in this field itself, about trying to understand who presents with localized disease and then goes on to have more aggressive disease, as opposed to those that have localized disease for decades. And we are still, as a group, working on a number of those different things. And Dr. Chaney, if you have had things to add.
Sure. So I agree with all of that. So things that I worry about being signs of progression of disease would again be if you're developing very extensive skin disease. If you've gone from having 3 spots on your skin and then all of a sudden you're covered, that's fairly unusual, but that would be something to definitely get checked. If your skin lesions are getting thicker, developing into tumors, and if you're noticing ulcerations happen in your skin or on your lesions, especially when you haven't bumped or hurt them, if all of a sudden they're scabbing and crusting and opening up, that's something that definitely needs to be checked. If you're getting red and scaly all over your body, and if your itch is getting much worse, that needs to be checked. And then, like Dr. Lechowicz said, swollen lymph nodes, weight loss, fatigue, where you have no energy, those are all things that need to be looked at. I believe there was one question on, is all LCT, which is large cell transformation, which is a change we see under the microscope, is that bad? So the traditional thinking is that large cell transformation shows that your cancer is more aggressive. I think it depends a little bit on what we see with our eyes too, in addition to what we see in the biopsy. If that was a biopsy of just a scaly, flat area on your skin, that may not signal that it's a poor prognosis. But if that is a big ulcerated tumor, then we're more concerned about that.
And then if I could take that a step further, or if for some reason it's noted within, some people will, as we talk about lymph nodes, if you see that within the lymph nodes itself, that has a very different connotation than from a skin biopsy. So we do have quite a number of debates would be a strong word, but conversations with regard to large cell transformation. And I think that it's an incredibly anxiety provoking thing for the patients when they're looking up their disease and they're seeing their pathology and what it means. And I would just stress to make sure that you're talking with your provider with regard to the context of what it means for your own individual disease, because there are different forms of large cell transformation.
Thank you both very much for the very informative answer with all of those questions in there. I have PCALCL of a single scalp lesion and involvement of 2 adjacent draining cervical lymph nodes successfully treated with CHP, chemo, and brentuximab. In terms of COVID risk, how long after chemo will I no longer be immunocompromised?
So I'm going to take this one.
That's all you.
Right. So, so I think that, so first of all, having that treatment of the BVCHP, I just want to say that that you're getting great care, and you're lucky to be with the person that's taking care of you. I think as we all know, in terms of COVID, we're still 2 years into this and learning a great deal as we go along. I think the part about chemotherapy in and of itself, what we think about is about the chemotherapy itself. And I usually tend to talk to patients. And again, we don't have a lot of great data on this, but chemotherapy, there's the right after you're done. And again, this is a generalized question. This is a generalized answer based on the question. Again, I would refer you back to your own physician with regard to how anyone did with regard to if they needed transfusions, if they needed growth factors, if they had delays in their treatment. All of those things are going to make things a little bit different, and what their counts look like once they were finished. I think the thing about COVID and chemotherapy in general is the idea that before we were used to these types of behaviors, that our patients, in terms of protecting ourselves, our patients were doing this for a long time. Usually within 6 weeks to 12 weeks, or the first 3 months, you'll get farther away from the direct effects of the chemotherapy. The brentuximab vedotin, and again, depending on how people use it, does have as a targeted agent to CD30, not only on the as we all recall, none of these things are only particular, even though they are targeted to just the cells that we want them to be targeted to. So there are a number of immune cells that have CD30 on them. In terms of an exact time, what I am normally thinking about, and your own physicians will take a look at different indicators in your immune system that will help to define, in terms of COVID, what your risks are. And then the next kind of caveat question to that we get on a hourly basis is with regard to how much immunity does one have, and timing of immunizations and boosters and the like, and that is continuing to evolve on frankly an hourly basis, especially with some of the newer antibodies and preventive things that are coming out from the FDA for people that are immunosuppressed. Again, I'm happy to would love to have my colleagues weigh in as well.
I don't know if I have much to say with the chemotherapy. I know we are occasionally checking antibody levels to the COVID, the spike protein in patients who needed chemotherapy right around the time they were getting immunized for COVID. But I think I'm not sure what my colleagues in Hem-Onc are doing for that. So I definitely defer to your expertise on that.
Sorry. I was going to say, and it's a incredibly good and common question, and the real answer is we don't know exactly, and especially I think, which I'll tend to say as well in our own group, in terms of cutaneous lymphomas in general, when you think about the immune system and having a lymphoma on your skin as the largest organ of the immune system, there's all kinds of questions with regard to that as well, that we also don't have the answers to.
Yes, COVID is something that is going to cause lots of questions for a very long time, it seems. What is B-cell transformation? We might need some clarification on that question, on what they're really looking for. So if the person that had sent that in is on, could put a comment in the chat, and we can try and get an answer for what you're looking for.
And I think just for whoever's going to clarify, because the lymphoma itself is mostly, as we know from the white blood cells that come from the T-cell, from the T-cell lineage of your lymphocytes, having a B-cell transformation is would be incredibly helpful for us to think about that. There are some etiologies that may sometimes look mixed, but it would be great for, as they said, for further clarification on that. But thank you for the question.
Some patients with cutaneous B-cell lymphoma can go from a more indolent lymphoma and transform to a more aggressive diffuse large B-cell lymphoma. So I'm not sure if that's what they're asking about, but we can comment more if that's what they mean.
Okay, thank you so much. Do I need to have a biopsy during UVB treatment?
I'm guessing they mean skin biopsy, and I think that would depend really on the situation. If you are developing some sort of lesion that your dermatologist is concerned could be skin cancer other than your cutaneous lymphoma, then yes, probably you do need a biopsy. If you develop some new sort of say you always had scaly flat patches and plaques of cutaneous lymphoma and all of a sudden you have a tumor, then that may need a biopsy, but we do not routinely do biopsies just during the course of phototherapy. That would not be a common situation. It would only be if we were concerned about something else.
Okay, thank you so much. So I am going to say we are down to about our last 15 minutes. And we still have almost 20 questions to go. So we might want to kind of get going on a little bit of our lightning round. So this next question, are there studies available that have looked at systemic T-cell ALCL patient outcomes at greater than 5 years diagnosis?
So I think that when we think about systemic lymphomas, for most of them, we end up thinking about we're thinking about 6-month survival, 1 year, 2-year progression-free and overall survival, and then 5-year survival. There have been some retrospective studies looking at longer, but that is incredibly rare, as unless I misread the question, thinking of it more of a systemic, as more of a systemic lymphoma, and 5 years, other than some subtypes, is usually is often our cutoff.
Okay, let's see our next question. Unless you have something to add, Dr. Chaney?
Nope, not on that one.
Okay. All right, so this one's a tough one, but we do get it a lot. What new treatments are on the horizon that show promise?
There are some new light-based treatments that may be coming soon. I really am not going to talk a lot about them. I'm not particularly familiar with most of them. I'm not an investigator for them. And for a couple of years, we've been hoping for a new topical medicine called reziquimod. If any of you have used something called imiquimod, it's something that we use topically off-label for cutaneous lymphoma sometime. I haven't heard anything. They've been talking about reziquimod since before I moved to Milwaukee. So we're getting on to like 10 years. So I'm not sure if that's actually still going forward. But I think there's a lot of things in sort of the systemic pipeline. Maybe Dr. Lechowicz could talk about that.
So I think that, right, an incredibly tough, I think from thinking about hope for the future, what I would say is there are a lot of people interested in these diseases and the disease entities, and working together to come up with newer treatments. I think from the point of view of is there the one thing that seems to be working 80% of the time, there is not at the moment. I think there are people looking at, as when we think about, there was some discussion about B-cell lymphoma or B-cell lymphomas earlier, that in the T-cell world we have some challenges in that in the immune system of T cells is a lot more complicated with regard to getting rid of the T cells to be able to eradicate the therapy and not leave someone immunocompromised for a long time. I think that being said, things that people are looking at particularly are looking at patients' individual diseases themselves and looking at them molecularly, and then trying to, but that's been looked at for decades in multiple different types of cancers, and trying to work on if there are different pathways that are seen or molecular changes that might make their disease more susceptible to certain types of treatment. We are in our infancy with regard to thinking about that as an approach, but I think it's something worth that people are continuing to talk about. But again, in terms of a certain kind of group of therapies or the like, T-cell lymphoma tends to still be a challenge with regard to how the immune system is going to respond.
And I'd like to add that we are planning on having a webinar coming up in relation to upcoming new treatments that are being worked on right now. And then I did have something come up in the chat. The question was asked about specifically a 5-year prognosis, and I think there might have been some confusion that it's just a 5-year prognosis. That person's question was just asking that. We're not saying it's only 5 years. So I just wanted to make sure I clarified that. And if that doesn't address your question, could you, the person who put the chat in, could you please add to it? Thank you. I have primary cutaneous marginal zone B-cell lymphoma. I understand the wait and see, but how long or what should you look for to start doing something more? I have a few lesions on my back, one on my shoulder, one on my eyebrow. I had injections on my eyebrow and back. The injection reduced the lesions, but then they returned slowly. Any recommendations on what to do next since the spots are not in one spot? And if we can leave the question up as they answer, it might help.
Dr. Lechowicz, do you want to start? Or I have some things about topical treatment.
Sure. So I think as always, so in terms of cutaneous B-cell lymphomas, there are a number of different things that we look for in terms of concerns for whether this is going to, I would assume, and again, as a general topic, that the person that you've seen has ensured that this is really only on your skin and it is not in other areas. There are a number of different things that can be, as long as we don't find anything else systemically, there are a number of other things that can be done. Watchful waiting is often done. Other things that one can think about, particularly if the lesions are in areas that are concerning or irritating, can be radiation. Can also be, at times we use more systemic sort of therapy, but in terms of, as always, there are toxicities with any of the things that we do, and trying to work at where the lesions are locally and minimizing toxicity is often the primary goal. As for the most part, these lesions tend to be, or the disease itself tends to be something that is chronic, and people are working with and managing for many years, if not decades.
Yes, I'll add my 2 cents on that one. So the good thing about cutaneous marginal zone lymphoma is that it tends to have a really excellent prognosis. Although people may get new lesions, it's very uncommon for them to develop it in a lymph node if it started in the skin only first. And so oftentimes we're deciding whether we want to just watch lesions in the skin or if we should go ahead and treat. So a lot of times if it's somewhere like an eyebrow where you don't like the appearance, where it can be disfiguring, sometimes we can do injections. I'm guessing that's a cortisone injection that you had. Occasionally that can be helpful, but they do sometimes come back. The second thing I tend to go to is to radiation therapy, like Dr. Lechowicz said. One thing I want to mention about radiation is not all radiation is the same. For these marginal zone lymphomas, if you have more than one lesion, oftentimes radiation oncologists are able to do very low dose, and our recommended number of treatments is just 2 for an individual lesion, and it's a very low dose of radiation for each of those treatments too. And oftentimes they will go away completely or for many years, and that tends to be very well tolerated.
Okay, thank you. We did receive a clarification on the prognosis, and the question was more, it sounded like prognosis was 6 months, 1 year, 2 years, or 5 years max. Could you clarify that?
So I think I said that. So I think when we're thinking about, and I apologize if that was, if I did not, it sounds like I did not explain that well, so I'm terribly sorry. When we are thinking about, usually when you see things reported about studies, we think about them with regard to those, we think about them with regard to those time frames. And that just gives us a sense of the disease itself. When you're talking about, and if I remember correctly, the question was regarding systemic anaplastic T-cell lymphoma, which is thought to be more, which may have cutaneous manifestations, but thought to be more of a systemic disease. And so when we're talking about 5 years, that doesn't mean that there's quite a number of people that are in remission much longer than that. We often do not follow out longer than 5 years, as the usual percentage of people's diseases, again, this being systemic anaplastic T-cell lymphoma. And again, there's some subtleties in between systemic disease as well, in terms of molecularly, if the patient has ALK positive versus ALK negative disease. But in terms of at the 5-year mark, that the chances of that disease coming back, particularly with different types of molecular with different types of showings of molecular is quite low. And that's what I meant by that. It doesn't mean that things stop after the 5 years. It means that it's unfortunately nothing related to cancer goes to zero. But in terms of being able to consider that the disease has a much smaller likelihood of coming back, 5 years is often the cutoff for long-term systemic lymphoma. That is not anything like what we're often talking about with our cutaneous B cell and cutaneous T cell lymphomas. And I hope that answers maybe my colleagues can help if I didn't answer that, if that didn't clarify it further.
Let me just see if I understand correctly. I think what Dr. Lechowicz is saying is people definitely live longer than 5 years, but we don't necessarily have measurements of how many people are alive at 10 years or 15 years after diagnosis or after treatment, just because that's not been studied, but it can happen.
Right. In terms of we follow people for much longer than that, but the 5-year mark is just one that happens to be what people are looking into with regard to long-term responses. But lots and lots of people are living much longer, and that's when they end up going into many times what we call survivorship clinic, where you're thinking about the cancer being behind you. And instead, what do we need to be doing with your primary care doctors about what your body has undergone, and thinking about your other organs as well.
Thank you so much for the clarification. So we're going to run just a couple minutes over to try and just get a couple more questions in. But what I want to do say, for the people that we don't get your questions, we are using some of the questions from today to start in our next mini video series. So if we didn't get to it today, we'll try and get them into our mini videos in the future. What type of response and side effects do you see for patients receiving romidepsin?
So I'm going to take this one. In terms of from romidepsin, it's been around for a number of years. in terms of, so some of the issue, I think there's response rates and side effects. So one of the things with regard to romidepsin is the concern for, usually what we do is have people, we check on their heart at a baseline ECG or electrocardiogram, looking for something in terms of looking at the level of the electricity within their heart and how their heart beats, because in the early years of the data for this drug, there were people that this drug actually prolonged the electricity, which made it harder for people's hearts to beat. We also look at people's other medications that they take to make sure there's not too many drugs that actually would interfere with the romidepsin. Other things that people will talk about are their platelets going down. Some people will have incredible nausea and fatigue. The thing that when we were doing the trial, the other things that people talked about were about food not tasting the same, and about incredible weight loss. I think the other things that people often talk about are just, as many may know who receive the drug, that the infusion is quite long. You also need to make sure of that your electrolytes are well in balance and be able to, and again, back to the cardiac issues with regard to that. In terms of overall responses, again, it always is. There's a little bit of a range with regard to staging and the like, but somewhere between, and a number of trials have actually worked with this as a single agent, have also worked with it in combination, so it's hard to say, but within kind of 35 to 55%, and again, depending on how the patient's other what we call comorbid illnesses or other diseases that they might have, will make part of the difference in the choice and or the treatment.
Thank you so much. So we're going to have time for 2 more questions. Our first one is, my daughter is being told she's in stage 1 of CTCL-MF. I'm confused as her whole body is being affected, literally head to toe.
I'm guessing that the question asker means that there are actually lesions, skin lesions all over her body. If so, then it's possible it may not be stage 1A. However, some people will have just a few lesions but be itchy all over their body. And in that case, if it's just symptoms without affecting how much skin is affected, just the itch all over your body does not necessarily change the stage. I hope that answers the question. But we measure how many lesions there are and what % of your body is affected. And your hand, your palm, including your thumb, is about 1%. So that's how we usually estimate.
Thank you so much. Okay, staying on the skin, my skin has become increasingly frail, cuts and bruising. Is there anything I can do to build up an armor or resistance?
This is a tricky question because there's a number of different things that can make people's skin more fragile. As we age, the inner layer of our skin, called the dermis, does get thinner, and that makes skin more liable to bruise or tear easily. Use of topical steroids on the skin can make this much worse. Any topical steroid, especially if they're really strong ones, can thin the skin and make you more likely to get cuts and bruises. Ultraviolet light over the long term, over many years, can do that as well. So I think a couple of things. If you are using topical steroids all over your whole body, that's a good discussion to have with your dermatologist if there's something else you can do, because that may be contributing. Sometimes we can use a topical medicine called a retinoid. They actually build up the skin slowly over time, and that can sometimes help a little bit. But I wish natural aging could be reversed, but it's not a perfect thing. So,
Okay, thank you so much. So that was our last question. So we're going to wrap up our program. I wanted to say thank you to both Doctors Chaney and Dr. Lechowicz for taking their time to do this for us. Dr. Chaney, do you have any final thoughts?
Nope, but thank you so much for having me. It was an honor to talk to everyone. Please, anyone, if you're having questions about your diagnosis, please reach out to your dermatologist or your oncologist or their office, because often their nurses are wonderful sources of information. And we hope that this has been really helpful for you.
Thank you. Dr. Lechowicz, any from you?
I would also like to thank again everybody for coming today to listen to us. I think the other thing I would maybe add is the fact, along with being partners with your dermatologist and or your oncologist, is there's this, as we all know, these are incredibly rare entities, and that I think you are you have a wonderful resource in the Cutaneous Lymphoma Foundation with regard to be able to finding, because there's a lot of information out there that is hard to interpret, and you've got a lot of resources in the Cutaneous Lymphoma Foundation. And remembering also, as we said, that this is a very rare these are very rare entities, and things are often changing quickly, although maybe not as quickly as we would like, in terms of if there's ever any questions, the Cutaneous Lymphoma Foundation can help direct you with many of your needs.
Thank you both again, and thank you everyone who attended. We look forward to seeing you again at our future programs, and have a great rest of your day.